This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.
Good evening. My name is Joe Sam Robinson, and it's my pleasure to have with us tonight Dr. Steve Wilson. Thank you for being here tonight with us, Steve. And there are lots of things we could talk about, but one of the issues that I guess is out there in the world is being a family physician, and that's what you are. Is that correct?
That is correct. Mm-hmm.
And that's something that's a difficult task, is it not, at this day and age? It's not an easy thing to do.
It wasn't easy when I got started either. So.
Well, maybe you could describe a little bit of your journey through life that brought you to Warner Robins and allowed you to practice family medicine. How did you're from Kentucky initially? How did things get started?
I'm a native of Louisville, Kentucky, and grew up there. My father was a family practitioner in Louisville, or well, a little town outside of Louisville called Linden, Kentucky, and I saw what he did for many, many years.
Yes.
I mean, he was one of the old Marcus Welby type doctors. He still delivered the babies.
Yes,
he would go see the patients at the hospital and so on. As he got older, his health got worse, and he had to give up the delivery of babies. But he delivered over 2,000 babies in his career.
Wow, that's a big number.
And that was a large number back then. And you know, he was from that generation where everybody was in their little solo practice. And
yes.
And you know, I admired my dad greatly for what he did.
Did people bring in cabbages to pay him and whatever? I mean, that's the story, isn't it?
Well,
I mean, if they bring in a country ham or whatever.
Well, we lived on a little mini farm outside Linden. We had several acres. We had our little truck farm in the back. That's where I got my interest in gardening from that. So we did. But we had people. It was not uncommon for some. I would sometimes come home. There's some guy painting the garage.
Yes,
to pay off his debt. It's things like that.
And that's the way the people were. I mean, that was the relationship a physician had with his patients.
That's
it was
correct.
not. It was a very, I guess, a good situation. I mean, in a way, a caring person, and there was a connection between the patient and the physician.
It was a very good thing, and I always admired that. So when throughout school, I was encouraged by many of my teachers to think about medicine as a career. I was always a quite good student, and so when I graduated from high school, I went off to the University of Kentucky, and I was honor student there, and of course was able to get into medical school at the University of Louisville.
Now, that's not such an easy journey, though. I mean, you had to take organic chemistry and lots of stuff there, lots of late nights, and not the easiest thing in the world.
No, I mean, it was 4 years of hard study and work.
Now, the basketball games didn't interfere with that?
I was in the band up there.
You are? Okay.
Now we're getting... The basketball games did not interfere with anything. We were at all of them.
Oh, I see that now.
We were at the football games, too, so marching in the football games.
Well, okay, now...
you have to do a little something.
See, we're getting into your true persona here. What was your instrument?
I was a baritone horn player.
A baritone horn player. Okay, so you were in the band, so it wasn't all study and hitting those. So occasionally other things happened. Okay.
I had a lot of fun with the band fakes. In fact, we've got an alumni band reunion coming up here at the end of October.
Oh, good.
So I'm going back. Been a while since I've done that, but we did have some fun. But then after you get off to medical school, then it gets real serious. But we still had fun in medical school with my classmates.
And you were in Louisville. That's
University
right.
of Louisville. Mm-hmm. And graduated there. And then after that, I came down to here to Georgia to do my residency in family practice over in Columbus, Georgia.
Yes. And so you had the interest all the way through. You thought that's what you wanted to do, with your father's example,
and when I went through school, I tried to keep an open mind and see what I really like to do.
Did you consider radiology? Just to toss that out.
I actually took my radiology class. I enjoyed radiology very much. I actually did well in radiology, but I just never considered it as a career.
So it's an emotional. You had just the emotional affinity for family practice, and that's many physicians just sort of find their niche. It's just an emotional relationship.
Yes. I found out two things I did not like to do. I was not a very good surgeon. There, I mean, you have some people who are just like yourself, gifted with the hands.
Yes.
And I just did not have that gift.
Yes.
And so I was not going to go into surgery. Now, my father delivered 2,000 babies, and I have to admit I did not like OB at all. So it was just one of those fields those two fields just did not appeal to me. But doing something else did appeal to me.
Yes.
And so when I made a decision to go into family practice, we looked at many different residency programs, and ultimately wound up matching at the one in Columbus.
Yes, and so were you married at that point? Or
No, I was a single guy at that point.
A single guy, you arrived in Columbus, and what year was that?
That was 1984.
1984.
And spent my 3 years over there doing the family practice residency. Now, I met my wife in Columbus.
Oh, you did?
She's from Columbus. And in fact, she was a nurse at the
and
hospital.
so you two met there. Well, that's a rather good story.
We didn't meet
there.
at the hospital.
No.
We actually met in church. We actually met in Sunday school.
Oh, that's a really quite good story. That's the best place to find a wife.
I'll tell it to you very quickly.
Okay.
First year I was there, you remember intern year.
Vaguely.
100 hour weeks.
Yes,
you're on
yes,
call every
right,
2 to 3
right,
nights.
yes,
It's
yes,
brutal.
yes.
You don't get a chance to do much of anything. One of my rare days off was a Saturday, and I do like to play golf, even though I'm not very good at it. Went out to the local golf course, and it was backed up and kind of busy.
Right,
and these
yes.
two people walked up behind me, a man and his teenage son. And they said, can we just join in and play off the last 4 or 5 holes together?
Yes.
He was the pastor of Hilton Terrace Baptist Church in Columbus.
Yes.
And he was a pretty good golfer. And his son was a real good golfer.
Yes.
So we played in, and he invited me to come to church. Well, I
Yes.
couldn't go the next day. I was on call. But the next weekend I went. Well, it reminded me of my little church up in Kentucky. It was about the same size.
Yes.
Friendly bunch of people.
Yes,
I wound up
right,
joining
yes,
the
yes.
church. Little did I know that my wife was already a member of the church.
There you go. There you go.
But she knew who I was because they know who all the interns and the residents are. She worked on the private
Yes,
med surge
yes,
floor
yes.
there, which one of the floors we never went on unless there was somebody dying.
Right, yes.
That was for the private patients. We were on the floors upstairs
Yes.
over at the medical center in Columbus.
Yes.
And so second year then comes along, and at that point in time, it goes to every third night call or every fourth night on some
Yes.
rotations. So I was able to do that, and I went there.
Yeah,
and
you were there
went to
before
church.
the 80-hour work week. Is that right?
Yes,
you were definitely
before the 8-hour work week.
Yes.
And but I went to church and started getting more involved with the church guys, playing some church
Yes,
basketball
yes,
and
yes.
playing some other things with
Yes.
the church guys. And you have to go to Sunday school if you're going to do
Sure,
that. So I
sure.
joined her Sunday school class, and it wasn't, well, needless to say.
And there you go. Well, that's a good story, isn't it? Well, that's a very nice story. And so you met your wife there, and you were married, and you were contemplating what's the next step.
We looked at a lot of different places to go. We decided we were either going to go here in Georgia or we were going to go back to Kentucky near my family.
Yes.
We ultimately did go back to Kentucky, and I took a job with the Lexington Clinic, big multi-specialty clinic.
Yes.
In Lexington, I was Dr. 105.
Right.
And I was in a small outlying clinic. I was actually in the capital city of Frankfurt, which is about 35 miles, if I remember correctly,
Yes.
35 miles from Lexington. And of course, the intention of the Lexington Clinic was to put all these satellite offices out
Right.
there. They had their own HMO that they owned at the time.
Right.
So they had all these insurance plans they were offering and wanted to have their docs in there.
Right.
Ultimately, though, that kind of soured because they sold their HMO to another company. Within 2 months, this company, I could no longer deal with
Right,
them.
right.
And I saw which way the clinic was going, and I just decided I had to do something different. So we decided to look down here at Warner Robins because my wife had some family and friends that lived here, in fact,
Yes.
still do, and they had invited us to come
Yes,
down here.
right.
And when we came down here in '89, well, actually late '88 when we looked at it, the situation here was quite good.
Yes.
I hate to say this, but several of the older doctors had retired
Yes.
down here, and there was just a crying opening for family practice
Yes.
doctors. So we moved down here in March of '89. I set up practice,
Yes.
and I was in solo practice and over on Carl Vinson Parkway. And I then built another office with another doctor here in town after a few years because things were
Yes,
booming. And so I wound up selling my half to him several years later, and then I moved back over to Carl Vinson
there you go.
Parkway.
Okay.
And that's why I've been there ever since. And so been fairly happy pretty much the whole time we've been here.
And so it's sort of, in a way, you're following your father's footsteps. I mean, he was a solo guy, and I mean, I think for the audience, one of the things to think about is the way healthcare is going. So we have a tradition, I think, of the physician, and he has bonded with his patients. I mean, that's a very reassuring situation. I mean, you're not a person that's part of a big factory. You're a person that has an intimate relationship with your patients, and that, in many ways, is the ideal of family practice, is it not? I mean,
That is one of them. You get to know your people over a period of time. I've got some patients that have been with me 22 years.
Yes.
I teach medical students too. I have them come from Mercer, but I also have recently picked up some from Morehouse up in Atlanta, and these are the upper level students. And some of them are just amazed. They all walk in and say, "Hi, Miss Jones. Hi, Miss Jackson. Hi, Mr. Smith. How are you doing today?" They know me. I know them.
Yes.
In fact, I could probably tell you what the problem's going to be before I even walk in the door, just knowing that they're there. And my students are beginning to learn that you can get to know these people over a period of time. You get to know their family dynamics, which in many cases is something very important to their health.
Yes.
You get to know them as a person, not just as a disease.
Yes, yes.
And I think that those are the types of things that they teach you in family practice, or at least they did. I hope they still do. At least I'm trying to. That these are just as important as knowing what that patient's blood pressure is, or what their hemoglobin A1C measurement of their diabetes is. Those are important things too, and I don't want to lose that.
Yes. So one of the things that happens, I think, in healthcare is we have the idea that we have lots and lots of tests, tertiary medicine. If your foot hurts, we'll do a trillion tests on you, and actually many times the person that's familiar with the patient has a sense of what's possible and what's not possible can really make things a lot more efficient. Say, well, I've seen your foot 12 times before. It looks okay to me. I don't think we need to imagine you have cancer there.
Right.
But if a person is just falls in the system, many times to reach that judgment is a quite expensive process. Is it not?
It is, and sometimes you have to know what you should be doing. I'll use your field as an example. I see an awful lot of patients that come in with neck pain.
Yes.
And I'll have some of these people come in with a neck ache, and they'll say, "Do I have a herniated disc? Do I need to go see a neurosurgeon?"
Right.
And it's kind of like, time out.
Yes.
Let's do the simple things first and see what you got first, and see if maybe we don't need to do that. Maybe a little physical therapy on you, maybe some medication, and you can avoid a neck surgery.
Yes, which is always good, I would say.
But at the same time, you've got to look at some of those patients, and somebody comes in and says, "My neck hurts, doc. Oh, by the way, my left arm here doesn't work."
That's right. If your arm is
and I've got this, and I'm going, "We're sending you to Dr. Robinson tomorrow."
Oh, that's good. That's good.
And that's, you've got to know how to do those sorts of things in my field. So.
Yes. Well, there are a lot of issues out there. I mean, and this is, as healthcare, we often talk about this on our little show about how the healthcare system is going and what's happening. We have these enormous changes that are underway and that are coming down the pike. And I mean, what are your views on that? What do you think is about to happen? What are some problems you see as a family practitioner here? I mean, what are the difficulties you face now in your work? And what might change, what for the good or not?
There's a lot of things going on in primary care, and I'll speak to family practice specifically. One of the things is when I first started, or in my father's day, we didn't have things like physician assistants and nurse practitioners.
Yes.
I have a nurse practitioner now. I've been working with them for many years, and they literally are my right hand.
Yes.
And they can see a lot of the common quick things that need to be seen. They can do a tremendous job of that. But then they'll give me the tougher ones, the ones that have heart failure, diabetes, hypertension, and so on. And I can use my skills for those sorts of people. We're evolving in family practice towards something called the medical home.
Yes.
Which is the intent that every patient should have a medical home where they go for most of their care. And that home may consist of somebody like myself with a nurse practitioner, or it may consist of a larger group that has, say, you have an internist as your primary doc, but you can see nurse practitioners, there's gynecologists in there, if it's a female, there's also other doctors involved. And you have these little integrated networks, and you can refer inside these networks. You share the information very easily via your electronic records, which I've been doing for 10 years. And the ability then to provide good quality care inside your little network, I think, or inside your little home, I think is there. And we're evolving toward that mechanism. Is that a good thing or is it a bad thing? I think it's potentially a very good thing, because then the patients will get to be seen over a period of time by the same people.
Yes.
And I think then that you will have the opportunity to streamline their care. They'll become more comfortable with you. You'll become more comfortable with them. You'll get to understand, why didn't you take your diabetes pill? Type of thing. And hopefully that'll provide better care for those patients who need it, who have those diseases that are the big problems that we have, like diabetes, hypertension, obesity, and so on. And I think that has an opportunity to be very good for us. The problem with that model that I personally see is I wonder if we're going to lose the personal touch of the individual doctor with the individual patient. It's going to be more of a group therapy session.
Yes.
We're all going to sit around and sing Kumbaya and
Yes,
hold
yes,
everybody's
yes,
hand and
yes.
type of thing, which in some cases you don't need to do.
Yes.
And some people really don't need that. So is that going to be something for them? I don't know. Is it really going to work for people like myself?
Yes.
I don't know. We'll see.
We'll see, yeah.
I do know there's always been a push in the last 2 or 3 reform efforts that I have seen to have more family practice doctors out there. We're probably 50,000 short of family practice
That's a
doctors.
big problem,
in
isn't
this
it? I mean,
country.
and there are reasons why people don't do that, and a lot of it is economics, isn't it? I mean, if you have a big debt and it's hard if you go through medical school or college and you borrowing money to do that, and there's a big debt that faces you, and it's a big problem.
I teach these medical students, and they go to, in many cases, to a private school. They come out of there $200,000 in debt.
Yes.
They have to work it off somehow. Many of them will go into the government, go
Yes.
into the military,
Yes.
go to an Indian reservation, something of this
Yes.
nature for a while. But when they come out of that, they're looking for a place to go. Many of them are gravitating toward hospitals,
Yes.
big networks, employed
Yes.
physicians.
Yes.
I was an employed physician for a couple of years.
Yes.
It had its positive benefits, yes, but it also had its big negatives too.
Yes. Yes. Yes.
And you have to weigh those. So a lot of people don't really want to go in. And if you're staring $200,000 in debt, and then after you get out, you want
Yes.
to get married, you want to have a house, you want to have kids, you want to have a car,
Right.
that sort of stuff, then it piles up, piles
Yes,
up, piles
yes,
up.
yes.
And to start your own practice is not cheap.
Yes.
So, that's another debt. So it's easier for them to take on a salaried position
Yes.
in many cases. And the other thing, of course, is that specialties pay more.
Yes.
Let's just be blunt. I
Yes.
mean, family practice, I don't know the exact figure, but I think we are down in like the bottom 4 or 5 of the pay scale right now.
Yes.
And, whereas other specialties pay
Yes.
much higher. We don't do bad.
Yes. Yes.
We don't do bad.
Yes.
You do better in some places than you do in
Yes,
others.
yes.
And it a little bit depends on how good your management skills are, but it's still the fact that you're not going to make as much as the cardiologist or the,
Yes,
or the
yes.
neurosurgeon. I hate to say that, but you guys go to school a lot longer, and you guys do a lot more things that we don't do. So there's some trade-off there.
Well, some of the things you mentioned are of consequence. You mentioned your mid-level providers, and that's really filling more and more of a niche.
It is.
I mean, is there resistance to having mid-level providers out there?
I
And
believe
what are your thoughts about that?
There has been some resistance to mid-level providers for a long time, especially among the physicians who would be my father's age.
Yes,
My father's
yes.
passed away now, but he would be mid-70s
Yes,
now.
yes.
And the older generation of physicians, they didn't work with those people. They didn't believe they
Yes,
needed them.
yes.
The people of my age I think there's some begrudging acceptance of them, and in many cases they have been, in some cases if you're looking for a partner or
Yes,
looking for new
yes.
associates, you can't find them, but you can go out and find a nurse practitioner,
Yes.
PA to at least fill in for a while. The younger physicians coming out of school, they work with them all the time in school, they work with them in the clinics,
Yes,
they work,
yes.
and there's no problem with working them as part of the team together. So in another 15, 20 years, I don't think it'll be any problem at all.
I think there's we're developing in the American healthcare system sort of a hierarchy of skills and talents, and I think there's a role for these mid-level providers. They fill a useful niche, and
I personally do believe they too. Now, the problem is, of course, is that what you don't want to do is have them go beyond their level of education.
that's right. They have to be carefully, as long as the doctor and the mid-level provider can work together, it works out very well, doesn't it? It
And
certainly
as
can.
long as you understand each other. I've had, my current nurse practitioner has been with me for 5 years.
Yes.
She understands her limitations, I know mine, and she can always come to me and say,
Yes.
what do you think about this EKG? What do you think about this
Yes,
X-ray? What do you
yes,
think about this
yes.
patient? Can you look at this? And there's a couple of times when I actually will send a patient over to her
Yes,
because
yes.
it's a little bit more in her expertise level. So it works pretty well for my patients to have that
Yes,
ability.
yes. Now, Steve, you mentioned, and kudos to you for doing this. For over 10 years, you've been doing medical electronic records, and maybe you could just, because this is about to be another card in the deck as far as the American healthcare system goes. Can you talk about what that is, and it's being mandated, and this is a big deal, and can make some
I did
comment?
it before it was mandated,
Yes.
so I did it because I wanted to. I saw the potential benefit in a lot of ways. The big things I see with electronic records is it's nothing more than a chart converted from paper to your little laptop or whatever or your iPad
Yes,
soon to be carrying
yes,
around.
yes.
And I've had my little laptop that I carry into my room, and my patients are very used to this
Yes,
now.
yes.
And the advantages are I can quickly look up a lab result.
Yes.
I can quickly go back. I had a lady the other day who was saying, I don't know if I ever tried that medicine. I quickly looked at all her old medicines, and I quickly found that in 2003, I gave you that medicine in 2003, and you had the following reaction to it. We can't use that. And so it helps that sort of thing. Medication interactions, big problem. You get these people who are on 7, 8, 10, 12 medicines, and I want to prescribe a new one on top of that or substitute. I'll click on the little button. It'll give me all the interactions. And it has saved me a lot of trouble, because then I can say, oh, you don't want that medicine. We'll try something else. Or it's just simply saved patients' problems. One example I'll give. I had a lady who was on a bunch of funny heart medicines for various arrhythmias, and I'm not something I prescribe often, but I put them in the electronic record. She had hurt her back, and I wanted to give her a muscle relaxer. I plugged in one of my favorite muscle relaxers and promptly got a little red box that popped up that says potentially fatal interaction between your muscle relaxer and one of those heart medicines. I would have never known that in a paper chart. I'd have had to go dig through a book looking up. This immediately gave it to me. I said, okay, we won't prescribe that one. We went and found something else to do. Saved a potential problem there. To me, that was well worth it. Now we're doing electronic prescribing. I click a couple buttons, hit the send button, it goes to CVS, Kroger's, wherever I send it. My patients get on and say bye. They don't lose these paper prescriptions. They go down the road, prescriptions waiting for them when they get there. That's great.
So technology really has the ability to make things work much better in healthcare, and you've given some examples.
I think it does. The big problem, of course, is you've got all these different electronic record systems from all these different companies. They're all some are based on Windows, some are based on this, some are based on that. They don't all talk to each other. And, for example, I bet that if your office had one, it's probably different than mine, and mine couldn't communicate with yours.
I think that's the case.
And that's the case. And hopefully we're going to get to the point where we're going to have these little health information exchanges. I know they're starting to set one up here at Houston Medical Center, whereby all of us can send our stuff in and out. That would have saved some problem I had the other day with a patient of mine who got admitted by orthopedic doctor for a shoulder replacement, and they called me up, and somehow by mistake they wound up calling another doctor in to see the patient, and they should have called me. I had to correct them with that, but the other doctor comes in and takes a look at this patient. Oh, you're diabetic, you've got this. Well, let's order this blizzard of tests on this patient. And he ordered this blizzard of tests on the patient. Well, if they'd had my records, they'd have known that I had ordered all those tests in the last 2 months, and those tests were completely unnecessary to be ordered again, which would have saved I don't know how many hundreds of dollars for that particular patient just in lab fees alone.
So this is a big deal, isn't it?
It is a big deal. And it could also save a situation where with a rise of the hospitalists out there, the hospitalists
sometimes... Why don't you say what a hospitalist is?
Okay, a hospitalist is a doctor who takes care of you when you're in the hospital for an acute illness. They are in practically every hospital around Middle Georgia that I know of. And oftentimes, if you don't have a regular doctor, this is who you'll get if you show up in the emergency room with pneumonia or a kidney stone or something like that. But oftentimes, your regular doctors, for whatever reason, may not go to a hospital. And a lot of family practitioners are not doing that nowadays. They turn them over to the hospitalist. Well, you need to make certain that that hospitalist knows your history.
Yes.
They know that you're allergic to this medicine or you didn't tolerate that medicine. So it's in my records.
Yes.
If it's in my records, I can transmit it over there. If I know that patient's in there, they can get that information and find out that, oh, Ms. Jones, you have pneumonia. We want to give you antibiotic X. But turns out you had a funny reaction to antibiotic X. So we can't do that. We're going to give you antibiotic Y. And there's reasons for doing these sorts of things. And they can help streamline your treatment, prevent unnecessary duplication of tests, without having to repeat a bunch of things that you just had done. I think it has the potential to make some savings go there. So,
well, that's some of the, as we look to, and I think there was a recent article in the Journal of the American Medical Association, and we beat this drum here a little bit, and it was recent. I was pleased to see it. I think maybe in the last issue about physician responsibility to control healthcare costs. And I mean, if we have ideas about how we can make things better, we need to step up to the plate and swing the bat. And I think the electronic medical records certainly have lots of good things they can do. And one of the things are making sure that the information is widely disseminated, particularly in the emergency room setting. And I think that's the issue that happens many times. A patient arrives from maybe another city or whatever with a poor historian, complicated complaints, and so it's the emergency room physician is just going to have to get to the bottom of this, and to do it, it turns out to be very, very time-consuming, expensive, bad use of healthcare resources. So that would be a very useful thing. Now, another thing that I think is in the hopper out there is that what's going to occur is we're going to have a gigantic amount of healthcare information that's going to be accessible to some kind of overarching agency, meaning the government.
Government, yeah.
And they're going to understand, I mean, it could be a bad thing, it could be a good thing. But they could say, well, we're pushing the button and we see that in Warner Robins, we had 12 diabetic deaths last month that shouldn't have been there, and we could do something about it. On the other hand, they could say, well, we've decided that people over 85 years old shouldn't be getting all this care, and then we found in Warner Robins they're getting too much care. It's a two-edged sword.
It is a double-edged sword, yes.
But it could be a very useful thing, and we just have to watch it carefully and make certain that the public interest is not diminished with the government having access to this information, which I think is the case. I mean, we know they're going to get it, or they not. Yes.
And not to mention the privacy issues.
Yes.
Because there's a lot of people don't want certain things in their medical records to be known to other people.
Yes.
And I can understand that.
Sure.
Part of what we took as an oath is that we're not going to reveal those sorts of things to people who don't really need to know.
Sure.
It's one thing if I have a patient who's HIV positive,
yes,
and I'm sending him to you because they need a surgery.
Right, sure.
You have to know that.
Yes,
you know, just simply because you're going to be operating on central blood
right,
and
sure,
all this
sure,
transmission.
Sure.
You've got to know that sort of information. But it may not be that the patient may not necessarily want that to be known.
Commonly, no, that's a reasonable thing.
And that's fine. We could use multiple other examples. So privacy issues have got to be resolved. And I think we're going to have to work through a lot of those over the next 10 years.
Well, that's a big thing. I mean, I think this is something that's too important for the government to handle alone. I would say that modestly. And I mean, we can't allow the government to become the prima facie, influence in our personal lives. I mean, we have our individual responsibilities. We have checks and balances in healthcare. And so we have to, as physicians, I think we have to say, well, this is appropriate, this is for the common good, but we have to be cautious about how information could be used for things that might be morally unacceptable. And that's particularly true because of the issues about reining in healthcare costs. That's a big deal, isn't it? And so this information is going to be out there, and how is that going to work? And it's going to be extremely important that this be done in an ethical way. I mean, and we have to be sure that's occurring. And so, as physicians, I think we have to
be very
make
cautious.
Sure that's the case.
Very cautious of that.
But there's certainly a lot of good that can come from it. I mean, just the data that one has access to gives all sorts of insights into. I can imagine great things happening. I mean, we could get with national collections of huge databases about different problems. It'll be a good thing. And also, maybe I think one of the things that often occurs is that a new idea comes along. It's a documented good idea, and everyone agrees that it's grade 1 clinical evidence, and we need to change the practice patterns and do that. I think this system will allow innovation to get out there and help people. It
certainly wouldn't hurt to have reminders on there. And for example, if we find a drug that we've been using a lot of,
yes,
that suddenly there's something new happens.
Yes.
I can recall a couple of diabetes drugs that we've had that suddenly been out for 8-10 years, and all of a sudden it pops up. Oh, we've found this cancer going on, or this liver problem, or something like that. The advantage of an electronic record system is that I can click on a couple of buttons, and find everybody in my practice is on that drug.
Yes.
And I can say, oh, need to start calling those people and say, we got a problem. Or the insurance companies can sometimes do that, or the government, or other people who can do that and say, okay, you've got 18 patients on this particular drug, it's coming off the market because of that. You need to switch them to something else, and then we can call those patients quickly with alerts and get them in and get them switched. And I think that would be helpful.
Well, we obviously are facing, rough water ahead as the country goes forward and tries to create a healthcare system that will reflect some financial limitations. And you're right on the front line. You're doing a good job, Steve. And just keep up the good work, and it's been a pleasure talking to you tonight. And
same here.
Go back in the vineyard and do your best.
Do my best.
Well, thanks so much
Thank
for
you.
coming tonight.
Appreciate
Thank
it.
you. Thanks. Thank you.
This program is brought to you by the Georgia Neurosurgical Institute. For over 50 years, rendering neurosurgical care to patients of all social conditions, treating complicated problems involving the brain, spine, spinal cord, and peripheral nerves, endeavoring to encourage quality care, medical research, innovation, and education on a local, national, and international basis.